The following webinar presentation comes from a previously recorded session sponsored by the AAMI Foundation on August 3, 2015, Alarm Management, From Confusion to Information to Wisdom. The webinar is part of AAMI's National Coalition for Alarm Management Safety, a national initiative that is designed to address alarm fatigue and improve alarm management. The webinar features a discussion between Kevin Smith, Director of NCH Healthcare System, and Samantha Jaques, Director of Biomedical Engineering at Texas Children's Hospital. Kevin and Samantha provide an overview on the alarm management problem and discuss how each of their organizations have attempted to solve it. Today's replay features the segment from Samantha Jaques. To listen to the complete one-hour session, visit the AAMI Foundation's National Coalition for Alarm Management Safety website.
Most of you are aware of why we're here today, right? Medical device alarm safety is one of the sentinel events that the Joint Commission has put out, as well as one of the national patient safety goals. So, right, in every room, right across all of our hospitals here in the States and abroad as well, there are hundreds of alarms that go off every day in those individual rooms. Those add up to thousands of alarms on individual units and tens of thousands of alarms within your hospital system on a day-to-day basis. From research, we know that 85 to 99% of those alarms are not clinically relevant. You don't need to do an intervention due to the alarm, and therefore, clinicians themselves have become very desensitized and overwhelmed by the alarm sounds. This has led to over 98 alarm reported events. 13 of those have been loss of function, 5 are around additional care extended stay, and 80 of them has resulted in death of the patient. And so this is why Joint Commission has really gotten involved with a Sentinel Alert event, as well as a national patient safety goal to help organizations tackle their alarm management problems. Next slide. So those of you who have been working on alarm management know that it's not a short, quick PDSA cycle that you can run to go ahead and fix your alarm management problem. There are a lot of hurdles that you need to get over in order to be successful in your alarm management journey. So first of all, we all know data is not very easy to come by, right? Every device you have in your hospital has different kinds of data that you can access in different ways, and they are not centrally available or easily adaptable to what you need in your organization. So actually getting the data out of the devices itself is the first hurdle that you need to overcome. Once you have the data, though, it's not an easy journey, right? First of all, there's very little literature or evidence-based guidelines on what to do around your alarm management problem. There aren't national standards as to what we set for alarm limits. There's not even standards based on patient type or patient age. So once you've gone ahead and tried to take your data and look at it for what you need to do, you quickly learn that the third hurdle we have to get over is that one solution does not fit all situations, units, and or institutions. Those of us working in the AAMI Coalition have found out that we have very different needs, right, on an alarm-by-alarm basis. The alarms that I have in my pediatric hospital need to be very different than those that Kevin has in his organization. Additionally, regional issues also occur, right? Hospitals that happen to be in Denver that are a mile above sea level, right, their physiological parameters are different because of where they are in the nation. And so the solution that you tailor for your organization has to fit to your organization, may even be unit specific. Last but not least, once we actually get all of the data, we figure out what we want to set our alarms at, we figure out what we're going to do for each unit in our institution, the last and probably hardest hurdle we need to get over is that culture is not very easy to change. Alarms historically have been one of those things that we've set it and forget it. And physicians have not been very helpful with our nursing staff and other ancillary partners to go ahead and figure out what to do around this issue. Bringing this issue to light, continuing to talk about it, and continuing to change your culture in a positive methodology is what you really need to do to go ahead and make a positive impact on your alarm management journey. Next slide. So those of you working in alarm management know that there is not one factor that causes alarms in your hospital. And so this is why it's very difficult to tackle this topic. So most of us are working in this first area where we're looking at our alarm settings, we're looking at limits, we're looking at delays. We've tried to prioritize our alarms. We've gone ahead and reviewed what our settings are. We've looked at what alarms go to our secondary device, what the delays are for those, and what kind of escalations we have. Unfortunately, tackling this is not the only thing that's going to help you solve your alarm management problem. Too often, artifacts in the signal cause false alarms. And so looking at electrode choice, prep placement, and replacement schedule is something your institution also needs to tackle. Next, we have to worry about what our clinical population looks like. So looking at a standard alarm set by patient population is helpful in eliminating those alarms for the patient population that you have currently on your unit. Now, ultimately, this reduces the number of alarms that you have on the unit. However, right, we're all driving towards setting individual alarms by patient so that we're not using a broad brushstroke to go ahead and set alarms for an entire population. Last but not least, but probably one of the most important things we need to tackle is education, both in the staff and the patient populations. So being able to educate your staff, both your nurses and your physicians, as well as enable and empower them to change their alarm limits, whether this is by physician order or to nurse sign-off. We need to give the staff the responsibility and the authority and autonomy to be able to make an impact in their alarm management. And then patients, right? We're not going to be able to solve our alarm management problem without educating our patients. We need to enable them and empower them to speak up about what's occurring in their rooms, as well as give them the information to understand why an alarm is important and why they can't mess with their devices to go ahead and shut those alarms off. We have been on an alarm management journey here at TCH for quite a while, right? So probably 10 years ago, we actually looked at 3 different things to try and reduce the number of alarms that we had. So first, right, we looked at the priority of alarms, and we set, right, is it a high, medium, or low type of alarm? We looked at the thresholds, right? Being a pediatric institution means that we actually have to have standards for our threshold limits based on age, because children, neonates, toddlers, teenagers all have very different normals when it comes to what their threshold should actually be. We also looked at what delays and escalations needed to be to our secondary notifications. What alarm went to the nurse's phone? How long did it wait to get to the nurse's phone? And that kind of thing. So this is work that we did probably a good 10 years ago, and we showed a great reduction, 66%, in the number of alarms that we had. Right, and so most of us thought, hey, we were done with this, right? You know, we've licked this alarm management thing. You know, our environment is the best that it could possibly be. Next slide. So we were a little shocked when we got some feedback from our magnet designee nursing partners down in the progressive care unit about some stuff that they were seeing. And so I'm going to give you a real example that actually occurred here at our organization. So Nurse Nancy, I talk quite often about her. She's a progressive care nurse, which is our step-down unit. She's been with TCH 15 years. In this day that she brought to our attention, right, she was assigned 3 patients for her 12-hour shift. She had an 8-year-old cystic fibrosis patient that was in her step-down post-lung transplant, a 2-year-old renal patient that had just finished his pheresis, and an 11-month-old post-heart surgery stepping down to the acute care unit. Because we had already set our limits and parameters based on age, she knew exactly what she needed to set her monitor at, and so I've put that there for you. Next slide, please. What actually happened, though, was very different, right? So in her 1 12-hour shift, her 3 patients had 336 alarms. During that shift, she spent 14% of her time in a state we call alarm flood, and that's defined as having more than 10 alarms in 10 minutes. That alarm flood is actually a very serious time in which, you know, the nurse doesn't know how to prioritize the care that she needs to deliver. So she is getting so many alarms that she doesn't know where to turn to go ahead and make her next intervention. During this day, she actually had 7 different floods, which equated to 2.25 hours of her shift. So during that time, right, her patients were in very high risk because she didn't know where to go ahead and take her effort and energy to go ahead and help her patients. On her secondary notification device, here it's a phone, more than 50% of her messages were either a warning or crisis alarm. And probably most shocking to me, right, during her 12-hour shift, there was actually only 70 minutes of her entire shift where there was not an alarm going off. Now, right, I'm an engineer. You know, I don't live in the nursing world, but I cannot imagine living in an environment where you have no time during the day to go ahead and actually do what you need to do for the patient. The environment that we had created here was one in which the nurse was actually worried more about the monitor and the alarms going off than she was the patient, right? We want to create an environment that is very patient-centric and have our staff actually focus on the patients and not necessarily on the devices. Next slide. So we re-engaged, right? We as an organization said, hey, we thought we licked this alarm management thing, but we haven't. So we really went and did another deep dive with a third-party vendor called Biomedical Informatics to help us understand actually what was going on our units. And we actually ran into some really interesting lessons learned. So first, right, alarms happen for very unusual reasons, right? At the beginning, I alluded to the fact that, right, there's 5 or 6 things that really cause most of the alarms. But in reality, you need to understand what your environment is. You need to understand the environmental factors that are around your patients and why or why not they may not be alarming, right? Is it that you need to worry about electrode changes? Or, in one of our instances, right, we had a pod room with 4 patients in it, and the trash can was broken. So it's a medical trash can, right? And I've got neonate infants, right, that when the trash can would open and slam shut, it would scare the patients. They would move. The movement artifact would cause alarms. There's nothing in that is very useful for the nurse to know that the garbage can had just closed. That's not an event we want them running to, right? So we have to understand our environment to know and mitigate some of those so that an alarm is actually something that our nurse needs to attend to. We also learned that the limits that we had set by age and unit really need to be data-driven, okay? So most of us have set our age and unit-specific data based on what we call normal, right? And so what I'm going to tell you is that literature normal, right, may not be normal for what your unit population is. And so I'll give you a great example, right? In pediatrics, right, normal children that are infants and neonates, right, their heart rate is much higher than an average normal heart rate. So a 180 or a 200 heart rate may be normal for them. However, right, when we went 10 years ago and set our age-based normals, right, we used that normal population to say, hey, yep, my normal is 200, so I will set my high threshold limit to 220. The problem comes in is that patient group that actually comes through your hospital is not normal. And so using literature that equates to a normal population, a normal healthy population, is not what we see in the hospital. So you should really be using the data that you derive on your units to define what your unit-based limits need to be. And finally, right, setting limits by age and unit are better, right, than using the defaults that come with your monitor. However, right, I'm going to echo what Kevin said. Being able to set your limits based on the individual patient need is the only way we're going to actually solve the alarm management problem, right? I may have set, what my alarm limits are for my unit. However, that may not match this one patient that comes into my hospital. And so we need to really identify what that individual patient's need is and set those alarms to that patient's actual physiology. Next slide. So we started a new way, right? We partnered with Biomedical Informatics. We looked at a way to create a real-time analytics dashboard. The dashboard actually has 3 layers to it. There's a unit-level dashboard, a nurse dashboard, and a patient dashboard. And it helps us use historical information and track all the changes that we do from our PDSA cycles, our improvement cycles. It also helps our nursing staff on the floor with their nurse assignments, right? The last thing you want to do is if you know you have 3 high alarming patients, you don't want to assign them to the same nurse. All you're going to do is you're going to stress that nurse out, right? And you're going to create a very high-risk environment where those patients may not get the care that they need. We also wanted to use this dashboard to help us leverage the ability to take real-time data and make clinical decisions at that individual patient level. Next slide. So this is what our unit dashboard looks like. And so this was actually a day back in May 4th, on our PCU, which again is our step-down unit. So on this day, there were 6,310 alarms. We also give some insight around what the nurse-to-bed ratio is, right? So in this case, each nurse was taking care of about 3.3 patients. The metric that we've started using to go ahead and try and track from a risk perspective is this time in flood. So how much of the time were our nurses in this flood event where they were getting more than 10 alerts in 10 minutes so that they don't know how to prioritize their care? We show the alarm load as well, which gives us a bar horizontally and vertically. The horizontal bar is where we are at today. The vertical bar is where we were yesterday, so we can kind of gauge, are we doing better or worse than yesterday? We also get a trend as well as what our most frequent alarm is. And for those of you doing alarm management work, SpO2 low is the biggest culprit of a lot of alarms. And in our instance, it's about 37% of the total alarms that happen. So this dashboard is actually available to all of our nurses via a website. and they can then click to get some more individualized information on what's going on the floor. Next slide. So once they click, this is a deep dive view that they can actually get. So on a particular day, right, they can get a listing of every bed that's on the unit and what the number of alarms that bed has. They can also get a ranking of what types of alarms were actually occurring and which one happened most often. And then finally, they can sort by clinical staff and determine how many individual alarms a specific nurse actually got during her shift. Next slide. We can then also deep dive by room. So this is bed 7015, and this individual bed had one patient in it for the 24 hours for the day. They had 329 alarms in that one day, and this is the listing of exactly the number of alarms that actually happened during those 24 hours. You can also see which two clinical staff in their 12-hour shifts were actually assigned. You'll actually note here something that those of us living in alarm management know, right? Alarms differ very differently between day and night. So you can see one staff member here got 207 alarms and the other one got 7. And so we know that there's differences between day and night, but we need to understand, right, why that's occurring. Is one nurse doing a better job of setting alarm limits for that individual patient versus the other one? Right? Is there more movement that occurs during the day that's creating all kinds of false alarms that we need to go ahead and look at? So data like this is very useful for your organization to go ahead and understand what's going on in the environment. Next slide. We can then also look by clinical staff member. So this is where our nursing staff on the units, our charge nurse, actually looks to determine, right, which bed should be assigned to which patient. Obviously, this isn't the first thing that they use to go ahead and assign beds to staff, but this is something that they take into account because they don't want to assign 3 really high alarming patients or 2 really high alarming patients to the same nurse. So in this instance, you can see, right, this clinical staff member had 3 patients assigned to her. One bed alarmed 160 times, the second was 117, and the third was a relatively low alarming bed at 67. However, we can start tracking, though, by this patient, how many floods this patient or this clinical staff member was in, how many alarms she got during that flood, and how much time of her shift was actually spent in flood. This is where we're focusing a lot of our time to try and reduce the number of alarms and the time in flood to make sure that we're reducing the risk on the floor. Next slide. Now, more specific, right, to exactly what Kevin was talking about is you've got to be able to set alarm limits based on your individual patient. And so it's really hard when you don't know a lot about that patient to understand what you need to set that alarm limit to. And so we've created a patient-specific dashboard that gives a history view of what alarms went off in the past 24 hours, as well as when those alarms occurred and what recommendations are being made to actually resetting those alarm limits. So I'll give you an example of this patient. This is actually one of our patients that was here in May. It's been de-identified for HIPAA reasons. But this patient has had 3 different alarms, mainly in the past 24 hours, an SpO2 low alarm, a respiratory high, and a respiratory low. So if you click to the next slide, what we can actually do is deep dive into that individual patient. So in the SpO2, right, this alarm went off 26 times for a total of 4 hours. And if you're a patient, can you manage an alarm going off 4 hours? That it boggles my mind, but it does. Our SpO2 low for this unit, the low limit is set to 90. However, right on the right-hand side, you can actually see the patient vitals for the unit population. So what we actually do is we take a look at the entire unit and create a histogram based on the unit as to what all the SpO2 measurements were over the past 24 hours. We can then compare on the bottom what those observed vitals are for that individual patient. So you can actually see, right, this patient goes between 100 and 91 most of the time for their SpO2 actual measurements. So maybe setting their limit at 90, right, might be a little bit high. Maybe we can move it down to 85, right, or something, to Kevin's point, that's actually clinically relevant. So we know what their physiology is. We can go ahead and set that alarm limit at something that's much more actionable. Next slide. So here's another a great example of that. So this is a respiratory low alarm that this patient has also been having. Now you'll note that the observed vitals for the unit population, right, kind of looks like a nice distribution that has a little bit of a tail on it, right? And so that normal for the unit population, though, looks nothing like the normal for our patient that's below it, right? Our patient has a huge spike at 11. That's where this patient sits almost all the time. So if 11 is normal, right, what should we really be setting the respiratory low limit to? And so that discussion can be had by our staff members, by our nurses and our physicians during rounds or at any time during the day because they have access to this data 24/7. Next slide. So this is the workflow that we've actually put in place to help our staff utilize this data and make clinical decisions. So at shift change, right, our nurse manager actually runs the unit report. They then use that report to set nursing assignments, right? This helps improve safety, reducing likelihood of alarm floods. Nurse manager then also looks at the patient list to highlight the patients for rounds review. So we all know that usually it's 20% of your patients that create 80% of your alarms. Those are the patients we want to highlight during our patient rounds. And so the nurse manager will pull that data for those patients and put an additional set of questions in the rounding template for our physicians and nurses and staff as they go around on patient rounds. So then during rounds, our clinical teams review those high alarming patients, and they actually have discussions in the room. They talk with our patients, they educate our patients, they educate our families, the nurses go ahead and provide input, and the clinical team then makes a decision to either change that alarm limit or they go ahead and keep the alarm limit as it is and change what we're actually doing to the patient as an intervention. So in our organization, kind of dissimilar from Kevin's institution allows nurses to change the limits, I believe with 2-nurse sign-off. Our institution requires a physician order. And so this is where we get our physician orders then during the rounding events so that nurses can then change those alarm limits. This helps us reduce our alarm volume and improves the actual environment that our patients are actually in.
Thank you for attending this webinar replay. As mentioned, this is a segment from a previously recorded session sponsored by AAMI. That session also featured Kevin Smith, Director at NCH Healthcare System. Go to the AAMI Foundation's National Coalition for Alarm Management Safety website if you'd like to listen to the full replay.